Hi, this is Rob Miner speaking to you from the western part of the United States in Montana about an interesting case that Jan asked me to present regarding severe iliac disease with a chronic total occlusion involving the femoral artery and severe bilateral calcified SFA disease. These lesions were treated using a combination of radial access, then contralateral right femoral and retrograde left pedal access, and then antegrade femoral access. As you can see here, there's a long chronic total occlusion of the left iliac artery extending into the common femoral artery and severe focal calcified bilateral SFA disease. This is a 66-year-old male with multiple risk factors for vascular disease who had undergone left iliac artery stenting in the past. He had stable bilateral calf claudication, but a new onset of left buttock symptoms. ABIs were very abnormal, with biphasic to monophasic waveforms in the right leg and monophasic waveforms in the left leg. Very minimal pulse in the right femoral artery, no palpable left femoral pulse, and 5-French radial access was used for the diagnostic angiogram. The big toe catheter is positioned above the renal arteries, and you can see here the iliac disease. Trailblazer catheter was then positioned to terminal aorta, and this gives you a good idea of what we're dealing with here, a right common iliac stenosis, and then left iliac disease that extends from a nipple, fortunately, in the common iliac artery, but does extend and involve the common femoral artery with an occluded profunda femoral artery. Trailblazer catheter was used to image the right lower extremity, and you will see the calcified disease and severe focal lesion here in the mid to distal right SFA, with 3-vessel tibial runoff being maintained and a large posterior tibial artery in the right leg. Here's the right SFA lesion, where there was 3-vessel tibial runoff, and the left SFA lesion with 2-vessel tibial runoff, but again, a large left posterior tibial artery. The first procedure, the right iliac artery was also stented during the diagnostic angiogram to facilitate access for the subsequent procedures using a long Cook sheath with 014 balloon technology and an entrust self-expanding stent, 8 by 80 millimeters that does fit through a 5-French sheath. Here's the predilatation with the balloon, the stent deployment from radial access using the 5-French sheath. And after this, the final angiogram following post-dilatation. In the second procedure, contralateral right femoral and retrograde left pedal access was then used. And for the benefits of the early and mid-career endovascular specialists, I wanted to briefly review the devices and techniques. A Materjame catheter was used to engage the left common iliac artery occlusion from right femoral access. A front runner CTO device, which tends to stay in the true lumen of the vessel, was advanced through this Materjame catheter across the occlusion. With the help of a Trailblazer, we were then able to extend our advancement to the level of the common femoral artery. And I think this is one of Jan's favorite catheters because we can do diagnostic angiography with it. We can measure distances from the radial access to the lesion. It can be used as a crossing catheter, and it can deliver both the snare guide wire and the spider embolic filter. During this case, an extra stiff angle glide wire was used through a glide catheter with an Amplatz gooseneck snare. Contralateral femoral access to the left iliac artery allowed the Materjame catheter to engage the origin of the CTO from the true lumen, and an angle glide wire was used to disrupt the cap. The front runner CTO device was then advanced through the Materjame catheter across the CTO and old stent, and the Materjame catheter was advanced over this device to the external iliac artery, exchanged for the Trailblazer microcatheter, and this was advanced to the common femoral artery but could not cross into the true lumen of the SFA. Snare guide wire was advanced to the tip of the Trailblazer. Retrograde access with a glide catheter or an angle glide wire was made to advance through the left SFA disease and enter the cap very easily of the CFA CTO and advance next to the Trailblazer. The snare was then used to capture the glide wire and remove it, exchanging it for a supportive guide wire, and a 7-French crossover sheath was then used to support the endovascular interventions performed during this procedure. Here's imaging from the retrograde pedal access demonstrating that the Trailblazer catheter had reached to the point of the cap. The cap was then easily traversed, and the snare guide wire was used to remove the glide wire through the right femoral sheath. Angioplasty was then performed using a submillimeter balloon. And this is the angiogram following angioplasty. I want to pay attention to the collateral seen here because we wanted to preserve these collaterals in the region of the common femoral artery if we could. Setting was first performed in the iliac segment using Viabahn stent grafts because of the long chronic total occlusion and the restenosis that had occurred in the previously implanted stent. These were overlapped and also used to cover a small dissection seen at the origin of the left common iliac artery on the subsequent angiogram, with the stent being deployed in a way that would cover the origin adequately. After post-deployment, you can see the previously implanted stents in the right common iliac artery and the Viabahn stent grafts going through the old iliac stent. An open cell self-expanding stent was then deployed across the collaterals we hope to preserve in the region of the common femoral artery. And subsequent angiography showed that they were in fact preserved. Completion angiogram after the iliac and common femoral treatment showed the severe calcified SFA disease that was treated during this procedure, and the temporary occlusion of the distal segment of the left posterior tibial artery by the sheath. Vessel prep was performed using a HawkOne atherectomy device with a spider filter delivered through the Trailblazer catheter. And drug-coated balloon angioplasty was also performed with the final angiogram showing an excellent result. On this image, you will see collaterals filling in to the earlier segment of the posterior tibial artery, which was only temporarily obstructed by the five-French sheath. The sheath was removed immediately at the end of the procedure, and a transradial band was used to seal the region of the puncture site. For the final procedure, the patient returned for antegrade right femoral access for treatment of the heavily calcified right SFA. Vessel prep again performed with the atherectomy device and spider filter protection. Final treatment involving a chocolate cutting balloon to further expand the calcified disease in the artery, followed by a drug-coated balloon. And before and after on the completion angiogram shows a very good result, particularly between 17 and 25, with maintenance of 3-vessel tibial runoff, with good flow into the pedal arch. My experience using distal filter embolic protection with atherectomy generally reveals findings such as this, where you see excellent filling into the vasculature of the foot without evidence for embolization. Outcome was good in this patient. I'm asking him to remain on dual antiplatelet therapy lifelong. He's had a cure of his claudication symptoms, and at 1 year has normal ABIs at rest and exercise. However, he hasn't quit smoking, and as you may know, Montana is Marlboro Man country. Lessons learned: radial access allows excellent peripheral imaging, and I believe ease in iliac stenting, with new and longer 5-French products needed to reach deeper into the SFA, popliteal, and tibial arteries. Dual access can reduce time and improve success in treating long CTOs of the iliac and SFA. My personal success rate is now 100% in my last 30 cases. Finally, the role for traditional surgery continues to decline with advances in vascular. Thank you very much.